Hello, everyone, and welcome to the Healthcare Inspired Podcast. This is season 4, episode 5, and I'm going to invite my co-host, Maya Turner, to the stage. Hello, Maya. How are you today?
Hello, beautiful. How are you?
Good. I miss you already. Oh my goodness.
I know. We've been spending so much time together. It's so cool. It's so cool.
So fun. So we'll let the audience in on where we were this past week. We were in Lawrence, Kansas over the weekend.
Such a beautiful town.
Isn't it
Shout out
gorgeous?
to that chapter. Yeah.
So beautiful. The fall was amazing. The leaves and the
tree lines are amazing there. Oh my gosh. Yes.
Yes. And I think we both agree it's one of our favorite times of the year.
Yes.
The
I'm a fall girl. I love fall colors.
Yes, the pumpkin
spice. We were not short.
Yes, we had our nails done, didn't we? Yeah, we had our nails done.
Oh, together. Yes, your event at the Man Nails.
Well, let's not go there. Yeah, I think all of us have had their share of experiences with different nail techs, some that might not intentionally hurt you, but then you get hurt and you're not sure what to do about it. So yeah, fun times.
They downplay it, right? They downplay it. And you're just like, why is this happening?
Yeah. So I don't know. Anyway, I had a good time though. And I'm looking forward to our next adventure, wherever that happens to be. And
yes.
Yeah.
Absolutely.
So this week, guys, we are back for an amazing, amazing episode. We decided to take compliance and specialize it into something that you all deal with every day, and it is part of compliance, the use of Modifier 25 and Modifier 59. So I think this is one of those things where we want to do what's right, and sometimes we don't know what that is when it comes to these modifiers.
Mm-hmm.
I don't know. I don't have the same experience as me, Maya, but when I was first learning to code, I hated modifiers. And I tell people this all the time. It was back in the year 2000 when I graduated high school. I went right into a class that next summer when I figured out what I was going to do. Decided to go into medical billing and coding because my family was already doing it. So it was like, oh, this sounds fun. I'll do this. So I went to my first class and I was like, what did I get myself into? Man. That was my first experience, over 20 years ago. And so I went into it and I was going through my book. Back then, the course that I took, they were using the Carol Buck manual, which I love.
Shout out to her.
So good. So great. I love that manual. So I was learning that. And I remember reading the E&M chapter. And it was, of course, a lot crazier back then, right? It was 95, 97 by then. But we learned both. Yeah, and I was like, what is this? Like, I don't get this. And then the modifiers, and I'm like, what? And so and I think that's why I initially jumped on the surgery bandwagon, thinking, okay, I just want to code surgery because it made sense to me.
Wrong.
You know? It made sense to me. And then I'm like, no, I still got to code
more modifiers in surgery than it is for E&M. So you just like,
I know, right? Here I go. Yep. And I was like, well, you know what? I'm just going to go head first into this. I had a great mentor who really got me through those first few years. And it was amazing because that's what you need, right? When you're in this, the beginning, I promise all of you out there that are new, we both have been where you are because you all start somewhere.
Yeah. And you know, when I got started, I'm sorry, go ahead. I'm sorry.
No, go ahead. Yeah.
No, I was going to say, you know, when you're doing medical billing classes, right? I think their knowledge of compliance is also very important because when I took a billing class back in the day, just like you, Jen, you know, they don't tell you about the compliant thing. They just teach from experience. And I don't think certification and compliance and all those things were really a key factor back in those days, right? There was much less accountability because in 2000, that was prior to them introducing the act of the compliance and things of that nature, because the HIPAA Act came out in 1996. But, you know, prior to that, the responsibility of the rack and all those audits and things like that didn't come until just a little bit later. So all of the accountability that is associated with that was not there. So the P2P edits, the NCCI table, they didn't teach you about that because they didn't know it, because they didn't care. And it was just slapping on whatever got paid. And it was not a lot of regulatory guidance from those billing classes that were like small, come take my class out billing. So I think it's really important for nowadays that there's a lot more accountability when it comes to billing, because there is a lot more consequences that are related to when it's done incorrectly.
Exactly. So the goal of this, episode today is really just we mentioned, to give you less hesitation, because those two modifiers, modifier 25 and 59, are the most overused and abused modifiers. And it's kind of like a catch-22. You need them, but you're scared to use them because you also know what has happened by not using them correctly. So you're like, should I, shouldn't I? Should I, shouldn't I? And it gets to be overwhelming, and then you just don't do anything and your claims deny anyway. So it's frustrating to an auditor. It's frustrating to a physician. It's frustrating all around to everyone, coders, everyone involved. It's frustrating. And we can no longer go back and say, well, this is what CPT says, or this is what this says, because yes, they're CPT modifiers. They're in the CPT code book, but you cannot rely on that definition completely, because payers don't always follow the true intent of those modifiers. And we'll talk about why. So let's, today, let's go ahead and start with modifier 25. So modifier 25 is significant, separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of the procedure or other service. Whew. Got through that one. Man, one of the longest descriptions.
Probably one of the longest descriptions of modifier, other than 58 and 78, 79. Those.
They're kind of just like a little wordy, right? So yeah. So let's break it down.
Okay.
My favorite part of that description is where it says from the procedure.
Yes.
So that's
the key.
Or service, yeah. So the service is what you're focusing on, and then you're trying to decide, right? Can I add an E&M? And I think we go the other way. We think, okay, the E&M is automatic, and then we're going to see the procedure. No. Once the procedure becomes the decision, we now have to decide, can we bill an E&M? Like that becomes the option. And I'll tell you another way we can obviously verify this is when you go and pull up your procedure to procedure edits. And I don't know how many of you do this, but this is an easy way to know whether or not, if your payer follows CMS, of course, they follow the NCCI, they follow those edits, it will tell you whether or not a modifier is needed. If you were to pull up your PCP edits, your procedure to procedure edits in Medicare, you look for your procedure, right? And you also look for the second column to see if an E&M code is there. You match up, let's say I'm in orthopedics. So let's say I'm going to match up my 20610 for my joint injection. And I'm going to match up a 99213, for instance, for an evaluation and management established level 3. If you go to that second column and where the level 3 is, you're going to see over to the right the indicator that tells you a modifier is necessary. There is not the need to add a 59, right? Because that is a procedure only modifier. The modifier goes on the second column code. So if the second code is bundled into the primary code, the modifier goes on the second code.
Right.
We know it can't be 59. So what would it be?
25.
There you go. So it's super easy once you figure it out. But I think a lot of people haven't figured it out, because guess what? We're still seeing 59s on E&M codes, and we're still seeing 25 on procedure codes. I think it.
There's a really good resource on the CGS website that gives points of reference for a modifier table. It's called the NCCI procedure to procedure lookup. And for those of you who aren't aware of that, that's something that you can utilize. You don't have to download the Excel spreadsheets. You could just literally go on that website and find it. But what we really need to really focus on here is what is separate, significant, and identifiable.
Yes.
And even if it's 59 or 25, can you know how you go to the eye doctor, right? And you do this? Can you see? You see the Snellen chart, and then you do this, right? So think of it that way. If you put your eye on one of those and you could still see, but your eye is still independently visualizing that, right? Then think of those 25 and 59 modifiers the same way. Are you still able to see if you were to cover it up, right? And you were visualizing what service was being performed, right? I always like to use comparisons because that way you're able to make a conscious decision on what's separate, significant, and identifiable, or a distinct procedure services. So significant and distinct, right? You got to think about those two terms. And when you think about those two terms and think about the eye, right? The eyes, when you're covering them up, are you able to identify what is being done if you covered one of those procedures or documentations up to identify what is being utilized? Would it go above and beyond what was originally performed, right? So there's two things. You got to look at the NCCI edits and you got to look at the documentation. CMS specifically states the documentation should support. I've been in auditing for way too long. And people get it mixed up all the time, but it's all about education. It's all about communication. So if the doctor and or the coder is not familiar or do not know the resources to utilize in order to bill for that type of service, it becomes an uphill battle, right? Up a slippery slope because you're not understanding. So you're still making the same mistake over and over again. Your claims are denied and your revenue is delayed. That's the last thing you need when you're trying to establish yourself in a practice.
And isn't that the definition of insanity? I think yeah, doing the same thing over and over again, expecting different results. Oh
my gosh!
I think,
or the hamster in the wheel, right?
Yeah.
So you're sending this claim over and over again, and what really is, and Jen, I know you're gonna agree with me, and all of those who've been on. You call the insurance company, you call customer service, you ask them why the claim was denied. They don't know the difference between modifier 25 and 59. So they try to ill-advise you. It's the code. It's a. You're like, wait a minute. I did X, Y, Z. Why can't you explain to me? So I think the bottom line, and this is just me. This is just me on my soapbox moment. People who are advising people on how to pay claims should know how to code.
Mm-hmm.
Hello. People who understand coding should advise people on how to get things paid. If you are working for an insurance company and you're working in customer service and you have no idea what a CPT code is, you have no idea what the code description is, don't advise people on the other line how to get their claim paid because you don't know. So stop talking about stuff you don't know. If you don't know how to advise, then don't say anything. I'm not sure. Maybe you should. Done. Stop looking for the insurance company to tell you how to get paid because they don't know. You need to go within and hire somebody like me and Jen to be able to train your team on how to look at codes and know when a payment is validated.
Oh, I think I like that idea, Maya. Now, I will say what I think is missing, and I may be wrong. I mean, maybe some insurance companies do this and I've just not experienced it. I'm not going to claim that I know everything, but having kind of like a triage where the person talking to them says, okay, this is a coding concern. Let me forward you to our coding department and you can discuss, and they can pull up the account and look at it with you. But the problem with that is they don't always have the operative note in front of them. So there needs to be a review process. So I feel like there should be like an escalation. If they're saying it's denied for this and you don't agree, then there should be a point in time where you can request a review before it's officially denied. I mean, that may take time. Yes, it may take resources, but I think we're at the point where we can't just keep letting them say what they're going to say and just be done with it. I know we have a lot of claims to work. I know we feel overworked in our medical offices, but there has to be some accountability and not just let it go, because the more we let it go, they count on that. And I'm not saying insurance companies, the people at the insurance company, you all are doing great work. You're doing what you can do, but it's the organization as a whole needs to do better. The entity
This
that
is
you
what
are working for needs to do better.
absolutely. And this is what I say when you call the insurance company, right? You're on the other line, you're working AR, right? It's always, you know how you had a 3-second rule, something falls on the floor, 3-second rule, right? I don't know that we practice that in my house because we don't like food going to waste. But I call it the 3-person rule. If you call the insurance company 3 times and you get the same answer, then 9 times out of 10, it's right. If you get 3 different answers, the 3rd time you call, you need to speak to somebody else. You know what? I'm not really getting a clear answer. I need to talk to somebody else. Please refer me to da 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 da. And a lot of times, once you get into that rhythm, you begin to educate yourself. Then you say, the person on the higher up is going to say, well, if you look at they'll be able to explain the denial code. Well, I don't necessarily agree with this because we did da 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 da. Well, then you need to talk to the next person. So yeah, there is an elevated process, but when you call 3 times and you get 3 different people, you need to escalate that call. Don't go with 3 different answers and then I don't know what's going on. No, it's about diligence, initiative, and persistence. I always say that when it comes to claims or anything. Diligence, initiative, and persistence, taking the DIP technique when you're in the office, when you're trying to get claims paid. The more diligent you are, the more likely you are going to be paid. But you have to take the initiative and be persistent about making sure that claim is paid.
I'm giving you a good example. So patient signs the insurance contract with the insurance, and then they're in that relationship. We personally are not in that relationship. We did not sign a contract. We're not legally responsible to explain the policy to the patient or explain what's going on to the patient. We are doing that as a service to them. We are offering to help bill their insurance. We don't have to do anything.
No.
We don't personally have to do it. That's why they sign that release that allows us to bill on their behalf, right?
Yes. Yes.
So that's us doing that. So it's a courtesy for us to know the policy ahead of time. So just because we're not in that same contract with that patient and the insurance, it is a courtesy on our part to understand it on their behalf, because we know they don't read it. They don't read that policy.
No.
And the people you're talking to on the phone, they don't always read their own policies. They don't have time for that, or they just don't do it, right? It's not part of their protocol. Although it should be. And so you ask them about something, they have not read their own policies. They're advising you on a canned response many times. Yeah. And that canned response may not have been updated based on the current policy. So there's a lot of things missing in that algorithm of this is the update to the newest policy, but it hasn't made it to maybe their desk to where they know how to respond according to the current guidance that's out there.
Yeah. I mean, and I think that there is a lot to be said about organizational training, right? Communication, education, right? But at the end of the day, it's all about educating yourself, right? And knowing better. To know better is to do better. Some accountability on somebody's behalf. If nobody is taking accountability, then how do you make that determination of what's right or what's wrong? You have to continue. You have to dig. You have to look at the policy. You have to look at the contract. You have to look at the type of policy. Is it an HMO? Is it a PPO? Is it an EPO? All those things make a difference on the type of coverage that's allowed, right? And then what is, adjustable, right? You could be submitting a claim that there should be a contractual allowance and you think you should be paid. But if you don't know the difference between those types of contracts, then it also makes a difference on the answer, right? And if the person you're calling still doesn't know the answer, then you're both looking at each other with a blank stare. It's a staring contest. What are you going to do? I don't know. What are you going to do?
Who's going to fake out? No, you're right. You're right. So going back to this modifier 25, we know how to deal with, we hope we've given you some guidance on how to talk to payers, but it is your responsibility to know what's right and wrong with that modifier. So let's go back to documentation. So let's say, for instance, you have a new patient. Remember NCCI manual. If you don't have that in front of you, you should read it. Many of the chapters of NCCI cover modifier 25. I usually go to my section for orthopedics, chapter 4, but there's a lot of other chapters that discuss this. But it does say you do not need to be, you can be a new patient and still need modifier 25. Because just because they're new does not mean that you automatically get the procedure. You still have to show separate work.
Right.
the procedure to procedure edits I mentioned earlier does not have the requirement of a modifier 25 with a new patient visit. That is true.
Correct.
It doesn't automatically hit an edit, but it doesn't mean it's right.
Correct.
It may still mean the payer wants the 25 because they want to see the extra work that was done, the evidence of that. So you may have come in for one thing, but the preoperative and postoperative work that is customary for that procedure is all that was done. Right. You haven't done anything over and above that preoperative and postoperative work because it's a minor procedure you're dealing with. That's the reason you add modifier 25.
Right.
The problem we come into is when payers decide to kind of make a departure from the intent of that procedure for a minor procedure and apply it to x-rays and labs, which make no sense from a documentation standpoint, from a clinical standpoint. Right. Those things are needed to diagnose the patient, so they should not be considered separate procedures.
Although I've seen NCCI edits that require a modifier 25, and I said, what? It throws me off. Not NCCI edits. I won't say NCCI EMR warnings.
Yeah.
There's a difference between warnings in a claim system and NCCI edits in a claim system. So let's distinguish those two. When you're dealing with an EMR, there are certain warnings, that front end warnings that come off that tell you that you can't do this. Are you sure you want to do this? Da 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 da. Those are warnings, but NCCI edits are guidelines that are based upon Medicare for minor and major procedures. So when you're dealing with those types of things, you have to be sure and you are able to distinguish the difference between a front end warning versus an NCCI edit. Those are two different things, and they should be very recognizable in the EMR system. But if you don't have an NCCI edit active, I won't go there, but I'll just say that it could be very challenging and labor intensive to get a claim paid because you don't have any edits and you're getting all these denials, and there was nothing out there in the system or built in the system to warn you of that.
100%. So we're allowed to bill a new patient visit with the procedure, and many times it is warranted because you've done the extra work. You have to examine them, but you're also going to consider, you've never seen them before. So you're going to consider maybe imaging, you're going to consider labs, you're going to consider maybe another procedure, you're going to send them out for something. That's all extra work. So a good example would be in orthopedics. You have a new patient, they come in and you realize you've done the x-ray and you have records you're reviewing, right? That's extra work you're looking at. And you know they have osteoarthritis. You're going to go ahead and do an injection that day. But you also have requested imaging. You're going to bill for the imaging, but it's still part of your decision-making process. So you're going to count that as an order. You're going to look at maybe giving them a prescription to take home with them. Outside of that injection, that's all extra stuff. Maybe they have an injury and you're not quite sure, what to do about it. You're going to give them an injection for the pain, but you're also going to order a procedure. This happens all the time.
Right.
All the time.
I also think, and not to pick on ortho, Jen, very specific. They're very point specific when it comes to their documentation. And a lot of times, in my experience, at least with the organization that I've worked with in the past, that it's very ... They came in for this, they came in for that, they came in for that. Well, and in most instances, when you ask them, they could tell you everything from beginning to end, what's wrong with the patient. But the documentation is 3 lines. And you're like, okay, I can't tell you what you've done is incorrect, but I can tell you if I were to look at this documentation to show how you should be paid for these additional services, it falls short. You need to unravel the string to why you are performing the service. If it is not documented, even if they came in, it was a new patient. If you don't show in the documentation that something was managed outside of the E&M and the decision to perform an additional service, then it becomes questionable. Even though you know everything in your head, the physician knows everything in their head about what would happen with that day. But if it's not proven in the work, you don't get paid for what you do. You get paid for what you document. So make it a story. Tell everybody what happened. So if someone off the street that doesn't know you, that doesn't work for the office, can absolutely positively identify that there was something wrong with this patient, you needed to do something more than just see the patient to provide relief because they had the knee pain, because they came in as a new patient. They came in, maybe it was a motor vehicle accident and they don't know what's going on. So they decide to give them an injection, right? But they still had to be evaluated after that part. So, going above and beyond is just not in your head. It needs to be documented regardless of what type of service is being provided.
Right. And it's easy for us to see where they come in for one thing and then they do the injection for something else. Like that's easy to see clearly.
Right.
But we still want to see the thought process behind it. What led you to that, additional workup you have to do. And I'm going to pick on prescription drug management for a second because it is one of the easiest ways to get you that 25, but you still can't just prescription given. You still have to follow the guidelines for using prescription drug management to get your E&M level. So that means telling us what the prescription is, the dosage, and the instructions. Right. Because outside of that, you're not managing anything.
Well, and also think that in addition to that, there needs to be the connection of the counseling, right, that's associated with the prescription or why they're giving the prescription. So if they have knee pain, it should be in the assessment and plan that this patient was given for knee pain. If it doesn't improve, then we'll proceed for more measures. Because usually the prescription management is usually a more reserved type of management of the pain until they decide something more needs to be done because there's no relief or So a lot of times patients like to go that method, start slow and then go to something more progressive as time progresses. But it definitely needs to be documented. Speaking of which, let's talk about when a patient comes in and there's a decision, right, for procedure. So they decide in the previous note that they're going to do something and the patient comes back. Is it planned or unplanned? So, that is a borderline. Like if you're getting the E&M and then the E&M assessment and plan, they say, okay, if this doesn't work, if this medication doesn't work, we're going to plan on given an injection. The patient returns for the injection and you try to bill an E&M service.
No, because you have documented evidence that that's what they're there for. You can't get around it. You have documented planned visit. Happens all the time. They still want an E&M. But I think there's the caveat of, they might be there just for that, but what else did you do besides that? Because there is an element of E&M in every minor procedure. You have to evaluate them and manage them during that visit. So that's all part of it. You, of course, check out the area. You're going to make sure that it's safe to go and you do all the precautions. You give them a consent. You're looking at that. And then you counsel them afterwards. That's all part of what you have to do. Outside of that, though, if you go beyond that and you're like, oh, you know what? I have this other thing going on. Well, then, you can talk about it. That's medically necessary and it's good medicine, right? Absolutely. So now let's jump to something that I want to share with everybody. And it's kind of exciting news. And we picked today to talk about it because we have some exciting news for a new, oh gosh, I'm so excited, Maya. I'm just so excited to share.
Bursting at the seams.
The guide for Modifier 25 that is going to be available on November 1st. So we're very excited about this. This is new. We are going to do one for Modifier 59. We are going to do one for other modifiers down the road, but we're going to start with Modifier 25 because it is the most requested education that we get on modifiers. So this will be accompanied by a webinar. Now we're going to start with our new, education platform that Maya and I are collaborating on that we announced previously. MeduTrain is going to be an exciting adventure for us, but we're going to make a modifier train a part of the initial education we roll out. And our webinars are going to be short, guys. We're not going to give you hour-long webinars, just little mini micro bursts, right, of education. So we're going to have like a 10, 15-minute webinar on different topics. And for our modifier training, we're going to everyone's going to get a free copy of this guide. But if you just want the guide, you can, of course, download that. There is a fee, but you will automatically get this with the webinar if you choose to purchase it. Mm-hmm. Just as a highlight, we want to offer CEUs to people, and we always love to do that, but they're costly. So we'll have a modifier pack. So whenever we get to the point where we have all this ready, you can purchase so many to get you a CEU because they're short. They're not going to be enough for a CEU on their own.
Right.
But
Absolutely.
we'll offer later on packages you can purchase with 4 or 5 that will get you to that hour requirement for a CEU. So
absolutely,
watch out for that coming very, very soon. So I'm excited for that. Really excited for that. So that's going to be fun to roll out. So watch for that. It's going to go out on social media and our website on Friday. So stay tuned for that. I can't believe we're almost to November, but it's crazy.
I know. It's been a whirlwind. Like this last quarter has been insane. It's been insane.
I know. So crazy. Well, now let's jump into Modifier 59. Now, we could talk for an entire hour on these modifiers individually. So I'm sorry that we can't spend the whole day with you guys. We'd love to. But we're going to talk about just the basics of 59. Things to keep you, things to keep you motivated on not hesitant to use this. Number one, again, guys, just don't put it on an E&M service. That's number one. Numero uno. Please don't put it on an E&M service. It's a procedure-only modifier.
Right.
And
or labs and pathology. I mean, no, not labs and radiology and path and lab.
So it's like a procedure, right? If it requires a 59. Now, if you don't have a procedure that is hitting an edit that says it is bundled to the other procedure you're doing, you don't need a modifier, guys. Unless the payer is weird and doesn't follow the normal description, like I always say they sometimes do.
Right.
So again, the definition indicates it's distinct and there's a reason why we use it. And CPT gives us several reasons that we use it. Separate lesion, separate encounter, separate physician. And then the nice thing is that CMS, back in 2015, they came out with their extender modifiers, the X modifiers, we call them, right? ESP, XU, I forget how that all goes, but separate encounter, separate practitioner, unusual overlapping service, etc., and separate site, right? So we often use the XS. I think it's our favorite because it's it's separate site. That's easy to see. But the XU is also used as kind of like a catch-all. And we want to be careful with it because the reason CMS had created these subset of modifiers is they want to better track why we're using 59. Because all of those 4 extras there, they came from the original concepts built into the CPT description of this modifier. They give you a list of things, right? So normally there's things that aren't captured in those 4 extenders that are still in the CPT definition. So those things would potentially fall under the XU because the other 3 X modifiers don't cover those situations. But they're still valid. They just want to know, okay, was it a separate provider, separate site, separate encounter? Those things they want to track. Right. Everything else that is still applicable is going to be the XU.
Right. Or the 59, because they kind of mean the same.
Right. Yeah. So it depends on the payer. And some payers say, okay, we'll accept both. And so that's kind of hard to figure out, right? So you got to read the policy very carefully. Read your payer policy. Yeah. They do give you guidance on when they want to see this. Medicare, you just always want to use it. I mean, just use the X modifiers regardless. If they come back and say they don't want it, for some reason, then you can do that. But use the X modifiers. Medicare has come out and said that's what they want.
Yeah, and there's a tip sheet, the MLN Matters that has a
so good
on that very subject, and it really is a must read for those of you who are not really sure about it. But then you can also come to me and Jen and ask us to provide some education on that. So
and I love it. I love that.
It's very, 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 very informative. And sometimes it could be a foreign language when you look at it, and you kind of need someone to kind of translate. That's where we can come in, or the Modifier 59 upcoming booklet would also be very, very helpful in that regard.
Right, exactly. So I think that those are things that we want to just keep you in mind. a procedure only, and it only goes on on those procedures if they're bundled. Not if they're not bundled, you don't need it. And I think that's where it comes in.
Yeah.
We're going to post later in our on our pages and on the show notes of this episode links to all of those resources. So if you
Yeah.
are listening to us on your favorite podcast station, Spotify, Apple, whatever it is, go to those show notes and you will see those downloads. And we're also going to put it, of course, on our website. So you'll see that later, our podcast website. We'll post that later. So just so you have that information. But I want to make sure we're clear on that. You need to see how the payers interpret this modifier and when it's not appropriate. And they do give you examples, right, of what they would consider. So you can have the confidence and less hesitation. So those are the two modifiers, guys. And we're going to go back and see, we have a couple questions from our audience. We don't want to ignore our audience that has a couple questions. So let's go back to review what we learned today. And let's ask Maya this question. What are your thoughts, Maya, with an office visit and an AWV, so annual wellness visit? The documentation, if they use a template and separate entries without the AWV documented, or a chief complaint or references to the office visit. So just overall, Maya, just tell us your thoughts on what we should know when we're trying to capture the office visit and the AWV with Modifier 25.
Well, one, you need to have all of the documentation requirements because there's two annual wellness visits. There's a 438, which is the initial, and then the AWV, this SAWV, which is subsequent. Documentation requirements are essential, right? But you also need to document the need to go above and beyond. So if they have the office visit and they're complaining of something, you should be able to identify what services were performed or addressed, I should say, to go beyond the annual wellness visit. So if they have elevated hypertension remember, in an annual wellness visit, an examination is not required. So if there's an examination to show that there is something that is an incidental finding and is being managed, then that's the way that I would go with that. I wouldn't necessarily just say that if a provider bills for it and there's no examination and everything is stable, then I wouldn't bill with that. You need to show something significant, separate, and identifiable, and the modifier should always go on the sick visit.
100%. Because that is the code that is bundled to the primary code. So again, you can always check yourself, go pull up your procedure edits, or your encoder, because your encoder is built off the data from the PTP edits. I don't know if you knew that or not. Not anything against our encoders, but if you can't afford an encoder, you can always pull that file from CMS, Control F, you're golden. It's there. That's where it comes from.
Or go to the NGS website that we'll give some reference to.
Absolutely. So that's a great reference too. So just remember that. Now, I have another question having to do with, of course, our ortho related stuff. And this is a good example because, again, you want to make sure you are looking to see if those two codes can be billed together without a modifier. Now, this one does require a modifier. So you have to decide, is it appropriate? So this is a good example of, yes, like, you have to do this for the patient. You had to evaluate them first, most likely. Unless they're coming back just to get a cast or just to get a strapping, like that doesn't usually happen. Usually there is some evaluation ahead of time, and usually there is something you're doing for them. So this is not an easy across the board 100% every time, but we have to look at the documentation. Do you have evidence that this is over and above what is normal for the visit? Do you have enough evidence of that? I mean, I don't know what else to say here.
I also think that, But what if they came from the ED and the only thing that the provider had to do was do the strapping of the shoulder? Was there enough documentation to show that the visit warranted, in addition to the strapping of the shoulder? Because there are certain things that are inherent to the procedure. There are certain examination elements that are inherent to the procedure. So when that happens, you got to be really careful about the procedure that's being billed. Did the doctor document anything? And we're talking about ortho, right? We're talking about strapping.
Yeah.
So, you got to be real careful about that, and to make sure that if they didn't come from the ED, that the documentation supports the visit. Remember, if you were to cover one eye, would you still be able to see the visit? Would you still be able to see the other service?
100%. And that's the key. And I think we're so used to, you automatically put it on there because we're trained that way. but we don't want to be on autopilot with these
Yeah.
modifiers. We got to
Yeah.
stop being on autopilot and think about what the purpose is. We want our physicians to get every bit of revenue that they possibly can, but what are they doing over and above what they're already getting paid for? We don't want them to double dip and their interest doesn't want to pay for things they're not actually doing or that are already included in another service. So
Right.
normally, yes, you are going to have some other things you're going to talk about with them when you do the casting. So just make sure that you're looking at that. So they might be established to you. You see them in the office after they were in the ER, and you have to evaluate them. You have to look at records, which requires you to pull from the data section external records reviewed. So that's another element you can use from another area of E&M to get your calculation of your level. So you have to
Right.
review records. You have to talk to the patient, but are you only talking about just a cast? Are you also doing other workup? And that's normally what
Mm-hmm.
happens. But if we see what Maya said earlier and we have like 3 sentences and we can't pull anything from that, then all we have is a
Mm-hmm.
casting. And it does happen occasionally. I would say my orthodox I've worked with are pretty good about giving a full description, but on
Not
occasion,
mine. Mm-mm.
on occasion,
You just like,
yeah, I get you. I know we
where's the
can't.
documentation?
Yeah, it's like I can't see it. Well, we can't solve every issue, but
Right.
we can at least advise on what's appropriate. So
Yeah.
make sure that we're looking at that. Now there are lots of modifiers we could talk about, and that we work
All day, every
together with
day, and
these
twice
all
on
day, every
Sunday.
day. Oh yes, and twice on. But we are at the end of time for today, and we are so grateful that you joined us, and we hope you enjoy more episodes coming soon. So next week we have our discussion, of course, on element number 2 of the compliance plan, and that is going to be discussing our compliance officers and compliance committees. We have some great information to share with you
Yeah.
about those departments, those entities in your organization, and how they can work together. And one thing I want to give you a little preview of is we're going to talk about supporting your compliance officers. One thing that we feel is something that's happening is they get to be viewed as the Tobys of the organization. And I think some of
Uh-oh.
you Office fans out there know what I'm talking about when I say Tobys, because they almost get kind of like built into like the HR concept. Like nobody likes HR, right? Nobody likes Toby, but
Right.
they're essential to the organization and they're part of your team. So I
Yeah.
want to encourage everyone to think of our compliance officers and our compliance committees as part of the team. They are
Mm-hmm.
essential. We cannot do our jobs without them. So
Right.
we're gonna shout out to compliance officers next week and give you all some good insights on that. So thank you for joining the Healthcare Inspired podcast, and we will